Two, one. Good evening, everyone. This is Batul, the moderator for today's session from IJCP, and I would like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our renowned stalwart who is present here with us today. Well, ma'am needs no introduction, but yet it's our great pleasure and honor to introduce her. She is none other than the very famous and renowned gynecologist, Dr. Vijay Lakshmi Sheshadari, ma'am. Ma'am is MBBS, MS, FICOG, FICMCH, CIMP, PGD MLE, consultant at the Department of Obstetrics and Gynecology at Sundaram Medical Foundation, Chennai. So, with ma'am's wonderful insights, we are going to talk about the topic for today, which is addressing unique gynecological issues in adolescence. Before moving on to the topic, let us have a brief look on what the topic says. So, adolescence is a critical period of growth and development, and it comes with its unique set of gynecological challenges. In this enlightening webinar, titled as Addressing Unique Gynecological Issues in Adolescence, where we will be exploring the complexities and nuances of adolescent gynecology. This session will provide valuable insights into the common and uncommon gynecological issues faced by adolescents and the best practices for managing them. Now, without any further delay, I would like to welcome ma'am at our forum and would like to hand over the session to her for her precious talk to begin. Ma'am, over to you.
Thank you, Batul, and thank you, the entire team, for giving me this opportunity. And let us move on straight away because I think the expectations are high because we need to really look into the unique gynecological issues in adolescents. And obviously, we won't be able to finish each and every topic and every detail, but we would try to do justice, maximum justice to the time allotted. When we talk about gynecological issues, we are having a plenty of them, but we also need to think that we need to handle them in slightly different way than we handle the gynecological issues in the adults, and that is why this topic carries a different significance. We know what is adolescence is a period between the childhood and the adulthood, and this adolescence is from 10 to 19 years of age according to the WHO classification. Why am I saying WHO? Is because there are other systems which classify this adolescence right up to 23, 24, 25 years. And but WHO, which we follow, is the age of adolescence 10 to 19 years, and it has early adolescence from 10 to 13 years and 13 to 18 years, and 18 to 19 years is late adolescence. Now, this is a period of rapid growth. We all know, apart from lots of sensitive issues, this is an area where we have a lot of physical growth, lot of psychological alterations, there are cognitive growth, social growth. Endocrinologically, there is an entire change in the internal and environmental milieu. And then, of course, a lot of emotions come down the way, and behaviorally also this is a very, very special age group. I'm really happy that this topic was given to me because it definitely needs lot of insight so that we handle these kids very sensibly and with lot of sensitivity. Now, when we talk of adolescent psychology and emotions, which I will just wind up in one slide, the reason being we are here to really elaborate on the gynecological issues, but it is very important that we understand why this age group is so very difficult to handle, because there are lots of neurotransmitters like glutamate, dopamine, and serotonin, which predominantly act here as excitatory, pleasure, and decision making, and mood and behavioral roles. And this gives rise to a very high confidence, competence, connection, character, caring, conscious, curiosity, and confusion in this age group. So, when we look at all these characters of the adolescents, we know how well we can handle them. This is a period of great stress and strain, storm and strife, says Stanley Hall, and this is so very true for this age group. The adolescents are very emotionally labile, and they have lot of love, anger, jealousy, and worry impinged along with everyday handling, and they expect recognition for self and identity, feel attracted to opposite sex. This is also a period when they start moving away from the parents or the family attachments to the peer groups. So, this is just an introduction to say, keeping all this in the background, we should be able to handle the gynecological issues as well. Of course, the neuroendocrinal angle and the involvement of lot of psychological issues need very special attention, and that perhaps can be taken at a later date in detail as well. The puberty is one element which we need to discuss at length, because adolescence is the age when the puberty sets in. We all know approximately 10 to 11 years is the age which culminates into sexual maturity. And this has got into an advancement over the years. Earlier years were seeing a little higher age group for the onset of puberty, but now it is almost set at 10 to 11 years, and sometimes even a little earlier, around 9 to 10 years. Appearance of the secondary sexual characteristics start coming in, but the physical growth happens in a year, thelarchy happens in 1 year, and then after that adrenarchy and pubarchy. We all as doctors and the gynecologists definitely know what thelarchy is: the development of breasts, which is the starting point along with an exuberant physical growth, and then adrenarchy and pubarchy, which gives rise to the pubic hairs and the axillary hairs. Adrenal glands start acting predominantly, and after about 1 to 1.6 years there is menarche or onset of menstruation. Now the all this lead to almost see 3 to 3.3 and a half years of this transition happens. And when this transition happens, there is adult type of a fat distribution. The breast development goes through Tanner stages, and that is how we describe, though it starts early, but then it goes through as even adrenarche and pubarchy happens. There is broadening and curving of hips into the adult female type. The axillary and pubic hair show up and gradually become thickened and coarse, and onset of menstruation happens, thereby causing menarche as the evidence based puberty. Now, this is, of course, influenced by lot of genetic factors, the environmental factors, and the nutritional factors, but these preponderantly do not really change the age of puberty much, but a little bit of 1 or 2 years this way and that way can change because of these factors. The endocrinological influences come on, and so we have primary sex characteristics. There is growth of the internal genitalia, the ovaries, the uterus, the vagina, and the clitoris and the labia, and the secondary sex characteristics with the growth of breasts, axillary and pubic hair, sweat glands, and hips. So it's very important when we manage these adolescents to be thorough with the endocrinological background as well, and therefore the alterations in the physiology which come on in this age group can be handled. The common adolescent gynecological issues, which is the topic for today, include the precocious and the delayed puberty, the menstrual irregularities, along with the dysmenorrhea, the sexual violence, exploitation, and ensuing issues, the pregnancy and the related issues, sexually transmitted diseases, polycystic ovaries, endometriosis, which are quite common in this age group, and then vulvovaginitis, vaginal discharges, obesity and hirsutism, which has, I think, obesity has become a very predominant factor to be talked about in this era, with more sticking on to the media whereas less of physical exercises in general. Contraception, of course, is also needed to be discussed, though sometimes we feel in adolescent, is it a little too premature a discussion? Vaccination, especially in relation to the human papilloma virus, the rubella, and the chickenpox, need to be asked about as well. All these issues can be well understood if we have a very good background knowledge of the reproductive anatomy, reproductive physiology, endocrinology, and hematology. Hematology, which influences the bleeding patterns, is also very important. So, it is important for all of us to be thorough with the anatomy, physiology, endocrinology happening in the reproductive tract, and the hematology, which exhibits the reasons therein. I'm not going to go into those anatomies and physiology, because today the focus would be on what are the common issues that we face, which are unique to this adolescent age group. How do we really manage them? And just the tips on how do we go ahead about it. Because this time it may not be really possible unless we divide them into definite chapters to be able to discuss everything in detail. We know at puberty there is a brief activation of, at birth there is a brief activation of the hypothalamo pituitary ovarian axis, which is also called as a mini puberty of infancy, under the influence of the maternal hormones. But then, and we often see there is some milkish discharge from the nipples of the baby. There are some vaginal discharges happening as well. But this regresses in the first 2 years of life, and then it goes on into a dormant state till adolescence, when the hypothalamus starts activated, gets into activation, and releases the GnRH in a pulsatile manner, which reaches the anterior pituitary, and FSH and LH, which are the gonadotrophins, the follicle stimulating hormone and the luteinizing hormone, which form the cornerstone of the entire reproductive physiology, are there to release and stimulate the ovaries, wherein the ovary oogenesis happens, estrogens are secreted, and then it acts on the uterus, vagina, and vulva. This is what happens in the puberty, at the puberty, and therefore there is an activation of the entire reproductive physiology. Now, precocious, the main two incidences which can happen, as I said, in the pubertal issues are the precocious puberty and the delayed puberty. Both need to be addressed, though we say at about 10 to 11 years is the average age of puberty nowadays, but we can have them even earlier, before 8 years of age, and then they would be called as precocious puberty, and the causes are many, but then we need not really think of all those complex causes, but we need to at least get into the details, so that we can manage them well. The causes could be central and peripheral, and the central are the gonadotrophin receptor hormone dependent, and peripheral are GnRH independent. So, when the central causes are enumerated, they are idiopathic, familial, genetic, either an injury to the central nervous system, withdrawal of sex steroids. Somebody is going through a sex steroid administration and suddenly gets withdrawn, or CNS tumors, tuberous sclerosis, neurofibromatosis, and Sturge-Weber syndrome. Some of them are common, some are uncommon, but we need to keep all of them in mind to do the workup. And they are all early, they cause early maturation and activation of the hypothalamo pituitary ovarian axis, and therefore there is an early puberty, very early puberty, called as precocious puberty. There is a list of peripheral causes as well, like congenital adrenal hyperplasia, the McCune-Albright syndrome, the gonadal tumors, the adrenal tumors, the exogenous sex steroids. All cause increased production of the sex steroids, and therefore result in the pubertal changes, and that is why there is a precocious puberty. So, keeping all these in mind, we will have to work on the girl and then try to reach onto a conclusion. When we talk of the precocious puberty, we know there are other neurological symptoms which can happen, like headaches, seizures, visual disturbances. There could be polyuria and polydipsia. There could be a family history, which is also supposed to be a cause for a precocious puberty, and then brain infections, exposure to sex steroids, linear growth acceleration, acanthosis nigricans, and cephaloid macules. When we look at the previous slide with all those causes, if we can keep this in mind and work on the possible symptomatology which can guide us to do further lab investigations or investigations to guide us to the diagnosis. The important point here is that though we can do by the bone age, the LH and FSH or luteinizing hormone and follicle stimulating hormone, the estradiol estimation, GnRH stimulation test, the pelvic scan, abdominal scan, MRI brain should always be done to reach to a diagnosis of the cause of the precocious puberty. Now, we have to keep in mind that there is something called as premature menarche, premature thelarche, premature adenarche. Not all of them, but individually. So, when we have them, they do not get included in the precocious puberty, because somebody can have a thelarche and then continue like that for a little more year, and the total duration may not be just 3.5 years before the menarche, but maybe a little more. We treat them in a different way because we look at the causes in a different way. So premature thelarche or adrenarche or menarche as an individual entity need to be differentially diagnosed from the precocious puberty, wherein all these happen in succession as in the any girl, and the only thing is the starting point is very early, and by 8 the girl has achieved puberty. Now, when we say the management of the precocious puberty, it is very important, as I said earlier, to keep in mind the central precocious puberty and the peripheral precocious puberty in mind, the causes, evaluate based on the causation, and then try to see where we are and then give the appropriate management. When very young age it starts, but then the rapid progression happens, or if there is a significantly advanced bone age, because then the vertical bone length or the vertical height is very short and they remain as dwarfs, we need to consider the treatment. If the adult height can be preserved, the psychosocial stresses can be avoided. That would be the achievement of the management goal, and therefore, these need to be kept in mind whenever we are managing an adolescent with precocious puberty. If we have pinned in the cause and are thinking of a central precocious puberty, the substitution happens with the GnRH agonists, because, as I said, it is a GnRH dependent cause which happens in the central. And whenever we are talking of a peripheral precocious puberty, the main problem is the excess production of the steroids, and we take off the source of steroids, whether it is exogenous or we substitute glucocorticoids in congenital adrenal hyperplasia, or sometimes even aromatase inhibitors like letrozole can be given, which can block the estrogen synthesis. So, keeping all this in mind, I don't think it would be very difficult for us to manage a precocious puberty whenever we diagnose, pinpoint the possible cause, keep the types of precocious puberty in mind, and accordingly give the substitution either with with the GnRH agonist, or take off the source of excess steroids, which has caused the precocious puberty. The delayed puberty. it is the other end of the spectrum, wherein even after 17 years, 18 years, nowadays they set the bar even at 17 years, there is no puberty. And the causes could be malnutrition or hypogonadotrophic hypogonadism, wherein there is a delay in the hypothalamo pituitary ovarian axis maturation. And it could be because of the panhypopituitarism, maybe because of any kind of pituitary tumors, or pituitary apoplexy, or pituitary growth, and chronic illnesses, severe persistent asthma, cystic fibrosis, and sickle cell anemia, and ulcerative colitis. All these form the functional causes of the hypogonadotrophic hypogonadism, meaning the gonadotrophins are also less, and the gonadal development or gonadal function is also less. And these functional causes can be transient, can be corrected, can be treated, and then the puberty can be achieved as well. Panhypopituitarism again is generally an irreversible phenomena, but sometimes if the cause can be restored, the hypopituitarism may get corrected, or if the diagnosis is already there, the substitution of the hormones, the pituitary hormones, can be done and puberty can be achieved. A constitutional delay could be the cause for the delayed puberty, or even Kallman syndrome could be there. The hypogonadotrophic hypogonadism, we have already seen what could be the causes. When we talk of a hypergonadotrophic hypogonadism, wherein the gonadotrophins are in excess but they fail to stimulate the gonads, the it could be because of the problem of the gonads. It could be an autoimmune destruction, like in diabetes mellitus or in Hashimoto's thyroiditis, or it could be because of a radiation ablation of the ovaries or in Turner syndrome. So, all these conditions, we can see that there will be a hypergonadotrophic levels, but the gonads will not be responding to them. And therefore, again, the lab tests will be able to reveal the basic issues. Now, clinical workup of whether it is a delayed puberty, we would be able to know through the complete blood count, the thyroid functions, the dehydroepiandrosterone sulfate, the insulin growth factors, the erythrocyte sedimentation rate to guide us on the immunological factors or the autoimmune states, and in luteinizing hormone and follicle stimulating hormone, and of course the estradiol. Karyotyping can also be worked out, where we can find out the Turner syndrome. Now, management here, because it is the target organ which is defective, where the gonadotrophins are sufficiently present, but the estrogens are not coming out of the ovaries, the substitution has to be by estrogens. Once the estrogen is restored and the cycle goes on, we can substitute both estrogens and progesterone to get a withdrawal bleeding, and the cycles can be restored. We must understand that whenever these delayed puberty states are corrected, quite often they do not revert. They will stay on, and then you can continue with the normally menstruating adolescent girls, and therefore the workup is really efficient if you can pinpoint the causes and substitute accordingly. Now, having known that the puberty could be at the proper age, or could be a delayed, or could be precocious, we move on to the menstrual irregularities and dysmenorrhea, which are quite common again here. And the anxious parents do come on with a lot of issues. We have to be very, very clear to understand that though menarche sets in, and then it is followed by the frequent periods, which could be very, very frequent every 15 days, or there could be regular periods, or there could be complete amenorrhea after the start of the menstruation at their menarche, or there could be irregular periods of amenorrhea or a heavy menstrual flow, and or maybe the duration could change, sometimes 5, sometimes 7, sometimes 2 days, and all those things. Scanty periods can also happen. Any pattern of irregularity can happen at this age, and not all the time you really need to treat. Why? Because for 2 to 3 years, it takes for the hypothalamo pituitary ovarian axis to settle down, what we call as a maturation of the HPO axis. So once we have understood that, we understand that the ovulatory dysfunction, especially anovulation, just like how we have problems at menopause, and during menopausal transition, it takes a little while for the body to understand and settle with the internal endocrinal milieu. The same way, for about 2 to 3 years, although the anxiety comes on and the parents represent coming on with the possible irregularities, it is important for us to reassure them and just keep a note of the possible additional symptoms, any symptoms, small or big, and go into the detailed history and then keep a follow up. Never reject a patient saying, "Oh, you are normal, keep going." See, sometimes after 3 years, also they may be continuing with these similar issues, and we may need to evaluate and work on them. So, reassure that for initial 2 to 3 years, just don't get bothered, don't take treatments, just give symptomatic management and lot of reassurance, and they should be able to settle themselves well. So it's very important for us to understand not to jump on to the detailed investigations and management in the beginning itself. The menstrual irregularities, when we talk about this, is I'm talking of the irregularities which are persistent, wherein they come keep coming, and even after 3 years, where we have given enough allowance for the HPO axis to settle, and then we need to evaluate. Sometimes we can use our discretion and need not go through the entire ambit of evaluation, but can stick on to partial evaluation and then try to go ahead with slowly stepping up our protocols or lab investigations. And when we talk of the endocrinopathies, there could be a thyroid dysfunction, hyperprolactinemia, primary pituitary disease, which will lead to panhypopituitarism and then the subsequent hypogonadotrophic hypogonadism, and then evaluate on the hypothalamic dysfunction. Sometimes the stress, obesity, eating disorders, they are so common in this age group that they can lead to the hypothalamic dysfunction, and therefore into the chain of the HPO axis. The primary ovarian insufficiency, of course, need to be ruled out when all this hypogonadotrophic hypogonadism are ruled out, and there is hypergonadotrophic hypogonadism. The ovarian insufficiency needs to be pinpointed as well. The hyperandrogenic states like polycystic ovary, the congenital adrenal hyperplasia, which are so commonly diagnosed at this age group, need to be taken care of as well. Hormone producing tumors, though we don't think they are very common, but then we need to keep them in mind because these are the sex hormone producing tumors which can give rise to an imbalance of the hormonal environment and can lead to menstrual irregularities. Iatrogenic, very much possible when without too much of allowance given to the HPO axis stabilization. Somebody starts them on either oral contraceptive pills or on some kind of progesterones. They themselves can cause irregular bleeding pattern, and therefore our target is to keep in mind that we ourselves should not be the cause for the menstrual irregularities. The uterine lesions, they are again not very uncommon, whether they are small or big. There could be multiple myomas, leiomyomas, or could be cystic adenomyosis. Generally, adenomyosis in full blown comes at a little later date, but there is an entity called a cystic adenomyosis which can appear in the adolescent age group, and that could be the cause for both the menstrual irregularities as well as a severe dysmenorrhea. Endometriosis, we all know it can appear even in the prepubertal age, and therefore, sometimes when the dysmenorrhea is so severe, they take us to the diagnosis of the endometriosis, ovarian endometriosis as well. And that could be the reason for our irregular menstrual cycles. Coagulopathies, the von Willebrand disease, or the platelet function disorders, though they might have existed from before, quite often they show up at the time of puberty or adolescence when the menstrual irregularities come on, and that could be the first opportunity when the girl is diagnosed with these states of von Willebrand disease, which is not very uncommon, and the platelet function disorders. The pregnancy can never be taken out of our armamentarium, though we don't want to really label an adolescent female unless they are really diagnosed of a pregnancy. But for us as practitioners, we cannot get away thinking that they will never be into this state. So the moment they go into the puberty and pregnancy can happen, and that needs to be thought about whenever there is an irregular presentation of the menstrual cycles. Medications, again, the long history, sometimes they might not come out with the true history of their medical diseases, or even having been on some hormonal medications which it can lead to irregular menstruation. Systemic illnesses and genital infections, including the sexually transmitted diseases or the vulvovaginal infections, need to be thought about. So, we have a long list of problems which we are thinking whenever there is a possibility of a menstrual irregularity which continues even after we give a time allowance of about 2 to 3 years for the stabilization of the maturation of the hypothalamic pituitary ovarian axis. And we need not really, as I said in the beginning, need not go through the entire ambit of investigations. We can go on in a serial way so that we don't scare them also, because medically we want to be clear, but at the same time the young girl comes with an irregular cycles and we write a complete battery of tests, doesn't go well with the parents as well. The management would definitely depend on the diagnosis, and therefore one after other, if we have ruled out and if we have arrived at a particular diagnosis, we can manage them both from the clinical history, how irregular the periods are, and then on the basis of the lab tests and on the basis of the ultrasound for the pelvis and other abdominal ultrasound in case it is required, and of course, differentially diagnosing them from other conditions. The treatment could be three pronged. Either we can just give symptomatic, or if we have come to a specific treatment of a particular disease state, we can give rise to an evidence based treatment, or it could be, and but most of them in this age group require a psychosocial support, and we need to tell them that along with the causation oriented treatment, there could be even a psychosocial support system which need to be inculcated into the management. Whenever we are resorting to the hormonal management or whatever hormone based medications, we need to give them very judiciously. We cannot really give a prescription and ask them to take them on continuously. We need to warn them that could be, there need to be a follow up. They need to present to us intermittently, regularly, whenever we are asking them to come on, so that the hormones could be stopped. Or they sometimes one prescription and they keep taking for years, and that is not a very good prescription. Now, the medical confidentiality takes a long drive into this, because whenever we have the medical confidentiality in place, we know we will be able to help them get that rapport with them, because this is such a sensitive age. The parents don't want these young girls with their problems to be known everywhere, and therefore it is important to whatever open discussions, and do not reveal them unless the patient herself requests. So sometimes the adolescent girls walk in all alone, sometimes with an attender by the side. And it's very important for us to know, well, who is that attender? Is it a parent, or is it her friend, or whoever? Because you may not be able to really reveal all the medical conditions and the possible treatments to the person who is accompanying. And if the person feels confident that this can be revealed, it has to be done. It is not just a legal requisite, it is a social responsibility, it is a medical responsibility as well. Why did I put hirsutism here? Hirsutism is no different from the hirsutism of the adulthood, but only thing is the unwanted terminal hair growth in the androgen dependent areas versus the hypertrichosis, which is in the androgen independent areas, need to be distinguished. And sometimes in this age group, they are so conscious of these excessive hair that they would want to discuss with. And initially, they might reach the dermatologist, but when they are told that it also has a gynecological cause, they may come to us. Basically, there could be, of course, non-androgenic cause, non-hyperandrogenic cause of hirsutism as well. But many of these hirsutism could be because of the hyperandrogenic states, either ovarian or adrenal in origin, because we know both of them can lead to androgen secretions. It could be a non tumor state or a tumorous state. The non classical congenital adrenal hyperplasia, the Cushing syndrome, polycystic ovarian disease, the drug induced causes, and the idiopathic all have to be kept in mind while we are discussing with them, and really go into a good history and examination part of the distribution of these hair and the character of these unwanted hair before we are able to diagnose. Sometimes they come after the dermatological consult and going through the management of these hair, like shaving or epilation or this. Then it is our duty to really look into the possible cause, possible distribution. Even without this, we can ask a clear question as to whether they are existent all the time, or is she meddling with them, because it is very important to think of these causes and try to control them, because the longer they are left back, it becomes even more difficult to remove them. History and evaluation takes a long role. The dihydroepiandrosterone sulfate, these hormone binding globulin, the HOMA index, ACTH stimulation test, FSH, LH, delta 4 androstenedione, and total testosterone are all important. You may go all in one shot, or you may be able to pinpoint based on the history and evaluation and do some of them. The cyproterone acetate, the spironolactone, the OCPs, finasterides, flutamides, and topical eflornithine form an important management strategies. Of course, need not be applied to every girl who walks in with hirsutism, but we can discuss with them, and these can help them if there is a real hirsute girl. Cosmetic management, of course, always comes handy, and they can manage because we all know they in this age they are so very conscious, so very emotionally labile, and they want to look nice. They want to not to be teased about with these features, and specific therapies can go on based on the diagnosis. Again, this age group, whatever management we do for any of the problems, any of the issues, psychological support is very, very important, and emotional support, a convincingly comfortable management of their problems is very, very important. Now we move on to a very sensitive and sexual issues which are not uncommon. And as a gynecologist, probably we are the first ones even to be approached by either the adolescent girl or by their parents. Sex education in the schools at the personal level or the interpersonal can always be done. And this, although nowadays we do know that through the media, through the Google and other things, they are able to get an ample idea on the sex education. The schools are doing their part, the teachers are able to guide them as well. But at the same time, when they ultimately come to us with a sexual issue, it is important for us to give them a sex education, either prophylactically or with some kind of a tipping. Now, adolescent pregnancy or the teenage pregnancy is very, very important to consider, and we all must be clear that it has lot of implications, not only for the adolescent girl but for us, the way we manage them, because these extremes of ages, at the upper end, in the in the perimenopausal age, as well as in the adolescent, all the complications of the pregnancy are going to be higher, and all the management issues would have to be given a good insight. Something called as physiological maturity, which is age at first conception minus age at menarche. So we can very well understand that if they can give a little 10 years or 12 years down the lane to be able to conceive for the first time, the results are much more rewarding. But otherwise, the earlier pregnancy happens during the adolescence, the complications are much more, and we know most of them are immature. Most of them are not ready to carry on with the pregnancy, and therefore the spontaneous abortions or even the induced abortion rates are very high in this age group if there is a pregnancy. Either they are unmarried or married, even if they, although legally they are not allowed, but they could be unmarried pregnancies, unwedded pregnancies, and there is always a possibility that they keep it hidden. They do not reveal it even to the parents or the family, and they do not approach. Sometimes we are approached, but the parents don't know. So, all these complex situations may come on. I'm sure all of us do have some kind of exposure to such cases. And when this happens, we have to resort to a multiple complex management. And the MTP Act 2021, which gives a lot of leverage for the, which is recently has been amended and has come as an act, compared to the earlier MTP Act of 1976. We do know that we have lot of rights and responsibilities endorsed legally, and we can, every one of us as practitioners, whatever level of practice we do, we need to understand this MTP Act to the core. I'm not going to go into the details of this act or the provisions therein, because that itself is a big chapter, but let us all read it intensively and get to know the various provisions the law has made for us. The sexual violence and abuse, now these could be whenever the pregnancy happens, it could be a result of an either an agreed sex, or sometimes it is a result of a sexual violence and abuse. An abused adolescent is traumatized, and again, we need to handle her with lot of care and sensitivity. The POXO Act 2020, Amendment Bill 2019, again has to be read very carefully, has to be kept in tips, because anybody in the OPD can walk in with these problems, and we should know our rights and regulations, how we need to handle, when to inform the police, when to inform the health officials, and how much confidentiality can we endorse therein, how secretly can we manage this, or sometimes there is a resistance from the adolescent, from the resistance from the parents, but at the same time we have our own duties to take care of the traumatized girl, and therefore we need to really look into this. So keep all this in mind. It's very, very important to keep them ahead of our practice so that we handle them well. Any sexual intercourse before the age of maturity, which is age of 18 years in Indian law, is considered as rape. So all the time we have to think of them whenever they come with these sexual issues, and these are all just the guidelines, just the points that I have enumerated, but all of them, all of us need to be thorough with these, and maybe someday if opportunity comes we can talk about these in detail. Preventive approaches are always there. Sex education can be in a brighter way. There could be a talk with the violence against the sexual violence. The HPV vaccination, we know, has come a long way in the national immunization programs. And because the target of the government now to prevent the cervical cancer and to bring it close to zero is work. The work is going on very heavily, and we need to address them at this age. Whenever the opportunity comes, whether the parents come or whether the girl herself comes, and HPV vaccination need to be given 9 years onwards. And there are different regimes: the quadrivalent, the bivalent, the double dose, a single dose. Nano vaccines, the 3 doses and all. But we need to educate them, because the maximum efficacy of HPV vaccination comes before their first intercourse. And then, of course, it dilutes a little the efficacy, but then it can still be given after marriage or after conception and delivery, or after, not during pregnancy we don't give, otherwise after delivery, and even till the age of, earlier we were thinking till the age of 32, but now they say even till the age of 45 can be given. Contraception, as I said earlier, is not out of armamentarium of the adolescents. We need to understand, sometimes when they embark with the sexual activity and they open up with their exposure, we can understand that they are already vigilant about contraception. But at the same time, it is our duty to discuss openly in case there are unmet needs of contraception for these young girls, because it is important that they do not end up into unwanted pregnancies. Whenever we talk of contraception, that does not mean that we are promoting the unnecessary sex or this, but it only means that they should avoid the complications of the sexual intimacies, which can crop up at this age group as well. So let adolescence be an enjoyable phase of life instead of being burdened with lots of issues. Whether it is the gynecologist or it is the general physician or the psychologist who can help them, it is always important that we ensure, with our medical background, the best in the adolescent, and we help those parents who are now perplexed with lot of issues of the adolescent age group. Thank you very much for your patient hearing. And of course, we can take up any pinpointed questions if there are, or we can keep the discussions going on in subsequent sessions. I thank the organizers for this opportunity, a very profuse opportunity, I would say, to discuss and the topic very close to my heart. Thank you very much.
Thank you so much, ma'am. Thank you for giving us such wonderful insights upon the topic that you have shared today with us on our platform. Thank you so much for doing that. We have received few questions, so with all your due permission, I would like to put across those questions to you. Ma'am, am I audible?
You are audible.
Yeah. So moving ahead with the question and answers, the first question is related to the challenges. So, what are the challenges in diagnosing and managing endometriosis in adolescents, and what treatment options are available?
Endometriosis, I really did not take in detail because it is not unique to this age group alone. But management wise, yes, we need to worry about because she has to still go through her entire menstrual and reproductive career. So that is a big challenge. Now, as we go ahead in the age group, in a higher age group, obviously we know they have already completed their family, or we know that we can manage them. But anyway, now the medical management has come on, and we can try medical management with the help of estrogens and progesterones. Endometriosis as such is a big topic, is a wide topic, and ideally I would think that we should talk about it in different age groups. Just the endometriosis in the younger age group, for those who are married, for those who have got the family completed, for those who are approaching the menopausal age group. In this age, it is not uncommon, and sometimes we do find little girls abstaining from the school, absenting themselves from the routines because they have severe painful menstruation. And that is one thing which is really challenging for the girl to put up with this. We all know the endometriosis always leads to severe dysmenorrhea, severe painful pain during periods, and therefore every period that she every period that she goes through, she has severe pain, and therefore it's a big challenge for her to go through her periods. And the best way we can do, see, we always say the management of endometriosis has to be either producing a state where the periods don't happen. So that means like pseudomenopause or pseudo pregnancy, meaning the periods don't happen, the secretions or the blood which is accumulated into the ovarian endometriotic pockets don't happen, and therefore they are relieved of the pain, because that is the root cause of the endometriotic pain. So when we if we can do that, produce a state of pseudomenopause by either a continuous progesterone or a continuous steroid based management, we can definitely give rise to, because we cannot give something where there is irreversible issues. We cannot do much of the surgeries, although big endometriotic cysts need to be removed, but otherwise we should not traumatize the residual ovary, that we have to take care. We cannot give her something which will cause her permanent secondary amenorrhea, that we cannot do. So that means we have to be very judicious in the use of the estrogens and progesterone, wherein we can give her a symptomatic relief by temporarily suspending the endometriotic cycles, and the cycles wherein the endometriotic deposits are reactivated. If endometriosis is a long standing condition, obviously there are adhesions because of the rupture of the ovarian endometriosis, and therefore the adhesions come on, and then there are pains as well. But how much can we give relief is depends on the extent, and the whether we can give symptomatic. Sometimes they are quite comfortable with just the symptomatic relief, some good painkillers during the periods, so that they just ward off those times. But then diagnosis has to be good, because whenever we are meddling with the hormones of the internal hormonal milieu, we say we have to be very careful. And I think someday you must bring out any speaker or anybody to talk about endometriosis alone, because it's a burning issue in different age groups. So how do we go ahead really managing them? all through, because it's a very sorry state of affairs when somebody goes through endometriosis, because the pain is so blistering. And one thing we all know, that the pain in endometriosis or the symptoms in endometriosis are not in proportion to the extent of the disease. Somebody who has a minimal endometriosis can have a very big symptomatology, and somebody who has heavy symptoms may have a very minimal disease. So we need to understand them, and adequate treatment needs to be given, so that whenever they get married, they do not have problems. We know endometriosis delays the fertility. But if they become fertile and they become pregnant, the endometriosis resolves temporarily during that pregnancy as well.
Thank you so much, ma'am. Thank you for answering that question. Definitely, we will keep this in mind and we will make sure that we definitely do a particular session completely dedicated to endometriosis, and so that our viewers get aware of this in different age groups, what kind of problems can be faced. So, we will definitely think about it and we will definitely try to execute this one. And moving ahead with this, that was a question from our viewers, and as of now, we don't have any other questions coming up from our viewers. But then again, ma'am, I would like to thank you and all our viewers for their heartfelt participation that they have shown by staying tuned throughout the session and putting across such interesting questions and feedbacks to us related to the topics. Thank you so much to all of them. And along with that, I would like to thank you, ma'am, for taking out your valuable time and for being here at our platform and sharing such wonderful insights and making us about the topic so clearly. So, thank you so much for that, ma'am. With
You
this,
are
I would like to take a last take home message from your end, and then we shall conclude the session here for today.
Take home message is, be aware. Adolescents can have their own problems. Never brush them aside, thinking that it is just a passing phase. But the most important thing in managing, as a physician, as a gynecologist, or as any caregiver, is handle them very sensibly and with lot of sensitivity, because they have just stepped into the reproductive phases, and it is important that do not get scared of the entire life which is ahead of them, and we handle them very very carefully, and at the same time be open to whatever problems they have, and we have to give them a very, what I should say is, hearing ears. We should be able to really accommodate their complaints, their problems, and need not all the time, they need not be brought in, because once we have diagnosed and done, maybe we can have a conversation with the parents or the people who are with her, so that they also are able to empathize with this girl who is going through issues in during adolescent. Thank you very much, Batul.
Thank you so much, ma'am. Thank you for such valuable take home message. And with this, we would like to conclude the session here for today. Until next time. Thank you so much, ma'am.
Thank you. I think I was on time. Yeah,
Yes,
exactly one
absolutely, ma'am.
hour.
Yeah.
Thank you. Thank you very
Thank
much.
you, ma'am. Thank you.
So I'll log out now.
Sure, ma'am.